This is the Inside the Boards podcast. You're listening to an archived episode of the 2017 Study Smarter series. If you'd like to help support Inside the Boards, go to InsideTheBoards.com and click the Support the ITB podcast on the homepage. As our thanks, you will get an ad-free version of the complete 2017 Study Smarter series for the USMLE Step 1 and COMLEX Level 1, and help us continue to provide this on-the-go audio resource for your board preparation. As always, thank you for listening. Today I have a very mysterious and special guest, the Brosencephalon. It's quite exciting to welcome you, bro. So, welcome.
Thank you, Patrick. Thanks for having me, on the podcast.
Yeah, absolutely. Thanks for what you've done to make learning facts much easier for medical students. But before we get into kind of like some didactic stuff, we got to deal with a big question. So I want to focus a little bit on who is the Brosencephalon. But before just asking that, on Reddit, in the subreddit medical school, question how I feel after Brosencephalon's identity is released by osmosis. And there's just a picture of a baby that looks like somebody just like startled. And with like 42 comments, everything ranging from, I would have preferred his name to be shrouded in mystery and intrigue. And then it gets a little more like metaphysical. The real Brosencephalon is all the friends we made along the way. How do we know that he is indeed the real Brosencephalon, though? Maybe I'm Brosencephalon. So people are wondering, who are you?
Absolutely. I probably get asked that the most, and especially so on the subreddit. They're an interesting bunch, and their support has really been motivating and fulfilling this whole way. But, Patrick, you're asking me this at a good time. I'm actually in the process of, getting brosencephalon.com deployed, and I want to start the whole snowball, get it rolling by writing my story, essentially. So this is a good, the question comes at a good time, I suppose.
Are you going to be offering like your own sort of flashcards or flashcard deck directly through your site?
Right now, probably just what's already existing. One of my motivations for making this site is just to centralize everything and also give myself a platform to answer a lot of the questions that come my way. I get so many questions about, how to incorporate flashcards properly, or just, people wanting to know my advice and what my thoughts are on a lot of topics. So that's the main goal right now. As for future content, trying to get my feet wet in everything, and we'll see where the road leads.
Awesome. All right. So on that subject, briefly, flashcards, should they incorporate flashcards? If so, how? What's your advice in this crunch time before step 1?
I guess one of the things that really drew me to flashcards was just how flexible they are. And this is part of what I'm going to write about. A lot of students that have used my work have come back to me and said, I relied on your stuff pretty heavily. Like it was my main source of, exposure to the content. And then there's, things on the other side of the spectrum where people say, I only used it to reinforce, certain weaknesses. I only used it sparingly. People say they used it every day. So I think, in terms of when is a good time to get flashcards into your toolkit, I think it's any time you feel ready. The flexibility is there to use it, just as I just explained, to use it really heavily, or to use it as a way to just supplement and round out weaknesses as a more of a peripheral tool. If people are looking to adopt flashcards going into step 1 studying, I think that's a great thing to consider. In terms of the nitty gritty, yes, that, Patrick, could very well be a podcast episode on its own.
Right. And maybe we should do that sometime.
We should. It's a great idea. Again, another thing I want to write about. I actually recently teamed up with Shiv, Rishi, and the other wonderful team members at Osmosis, and we put together a webinar in early January exactly on what you're talking about, on how to write good flashcards. So I would certainly direct people to that. As a good starting point, we talk a lot about the literature and sort of the learning science that supports flashcard use. And we go through some tips on just how to really employ it into your workflow and how to start writing cards on your own.
How did you start? Why did you choose Anki, and what got you going in terms of writing flashcards?
The way I sort of got into that, and I guess into the whole Brosencephalon thing, was just I wanted to become a better student. I was sitting there, I guess, end of first year or near the end of first year, and I just wanted to make a change. Everyone always says, oh, second year is the darkest year of med school, right? Everyone warns us that the volume of material is going to go up, that the time you have to spend with the material has to go up. So I just wanted to become more efficient to prepare for that, to give myself more time to spend with the material, but also just to take care of myself better. More time to lift, more time to watch movies and keep up with my hobbies, whatever it was. So the way I got into flashcards was essentially through the internet, the subreddit on Reddit, the medical school community over there.
Yeah.
Anki wasn't too big at that time, but flashcards was an idea that got thrown around a lot, especially because, there's all the Qbanks that people are using to sort of test themselves. So people were sort of flirting with the idea of flashcards. I decided to try it on my own too, and at that point it was enticing to me because I sort of wanted to space myself from what I felt was weighing me down in first year.
Yeah.
I was taking a lot of handwritten notes, which was effective, and I was doing really well, and it kept me afloat in undergrad. But sort of how I was just saying, I just wanted to become more efficient, and there was certainly room for improvement as well. So I saw flashcards as a way to space myself from that mechanical aspect of studying. The added benefits was also, it was cross-platform. I could use it on my phone. I could use them on my laptop. I could also use them anywhere and at any time. If I'm in line at Starbucks or at the Tim Hortons or whatever it is, I could pull out my flashcards and just make use of the time. So that was very enticing to me because just, being efficient was the name of the game. And I felt like I could become a considerably better student if I just focused on becoming more efficient.
Absolutely. And how did you come up with the name Brosencephalon?
So another popular question. So everyone knows what the prosencephalon is.
Right. Or at least vaguely remembers.
For sure. I don't know where or how I got this idea, but I decided to make one of those bro word plays with prosencephalon.
Yeah.
Sort of how the way people say, it's all good, Brosencephalon or whatever, just to make a play on the word bro.
A med-ed portmanteau.
Exactly. And that was just my Reddit username. But then as things unfolded down the line, the name stuck and it sort of became the name that people use for my work.
Well, that's awesome. I think it's definitely an honor to have you here. I thought for sure when I found out you had matched that it would have been into something like neuro, but that's not actually true, is it?
No, I matched into internal medicine. I'm very excited for that. But yeah, actually, you're not the first one to say that. A number of people have just sort of thought because of the name Brosencephalon that I'm really huge into neuro and I was headed in that direction. I love neuro, but I'm very happy that I ended up in IM for sure.
All right. So the other thing I bet you get a lot is how do people get your content? What's the best way to get a hold of the Bros deck?
Mm-hmm. So that's probably, like I said, one of the biggest motivators for me to make my website.
Yeah.
So right now, a lot of my work is scattered around the internet, mostly on Reddit. And a big part of that is because after I had released, I guess what I can call now the first version of my flashcards, the community sort of just took it onto themselves to keep it updated, to change any errors that were in there, to delete any duplicates, to improve the tagging system in the cards. So it sort of just evolved on its own, and I really had no hand in this. People took it upon themselves to sort of dive into the flashcards and just make it more organized and trim the fat a little bit. So I guess updated versions of what was originally released can be found on Reddit mostly if you give a search for it. But my end goal with the website is to have all of that centralized on brosencephalon.com, just because so many students are really having to dig for access to these cards. And, perhaps I'm a little late in setting all this up, but I think going forward, I think going forward, that'll solve a lot of obstacles for students who are just sort of picking up med school and picking up new study techniques.
Now, Osmosis used or employed some of your content, correct?
Mm-hmm.
So some of the flashcards, there's a Bros pack how does that work?
I guess, what's the good word here? I guess in conjunction with the Robert Wood Johnson Foundation, when Osmosis was sort of developing their open resource, their open question bank and whatnot, they had approached me, through the RWJF to sort of contribute as a content contributor towards the resource that they were putting together. And I thought that was a great opportunity for me. And so I essentially just sent them the collection of flashcards. There's about 16,000 of them that I put together and release. And they've sort of taken that and not only used it as a framework, but just sort of thrown it into their database. And it feels good to be part of a project like that.
Yeah, absolutely. So people should also check out Osmosis Prime. You can get the mysterious Brosencephalon flashcards integrated within their own flashcard database. So
yeah, they do some great stuff.
All right, let's get into some learning. You are going into internal medicine, so we are going to discuss a little bit about cardiology today, everybody's favorite subject. Well, maybe not everyone's, but it was one of mine. So let's do some questions. This will be a shared internal medicine OBGYN question to start. So a 33-year-old G2P1 comes to the office because of poor diabetic control. She is currently at 18 weeks gestation and admits to having poor control of her type 1 diabetes. Family history is non-contributory, and examination shows a gravid abdomen with a fundal height of 19 centimeters. An abdominal ultrasound is ordered. Which of the following is the most likely congenital abnormality shown on the ultrasound? A, amelia, B, anencephaly, C, sacral agenesis, D, spina bifida, or E, ventriculoseptal defect. And the answer here, well, do you want me to give the answer? Because some participants want to think through them out loud.
Sure, we can go through this question, actually.
All right. So you guys think about that. Which is the following is the most likely abnormality on ultrasound? And we'll get to the answer. Walk us through it.
Right. So I guess this is a good time to, just mention one of the strategies that I feel really helped me with these board-style questions, before we dive into the other ones.
Yeah.
And it's a really simple thing that a resident I was rotating with sort of opened my eyes to. And it was just to always read the first sentence of the question of the vignette and then read the question line of the vignette before you dive into the actual details. So I find that it saves me time while reading the vignette. I can point out red herrings a lot more easily. And it also puts emphasis on keywords like most likely or least likely or best next step or the best first step, which a lot of the times makes or breaks, a question whether or not you struggle with it. So I think here, knowing most likely congenital abnormality is really important because a lot of these certainly are common and are associated with the issue in this pregnancy, which is uncontrolled or poorly controlled type 1 diabetes. So just saying that and keeping in mind most likely, and then as well from your knowledge base, from the flashcards or whatever you're using to access the content, knowing the association with diabetes and congenital heart defects is essentially the missing link here, and will point you towards ventricular septal defect.
That's the correct answer. So yeah. I think this is sort of like an interesting question and raises a few issues. And I think I've pointed this out before on our podcast, but every board style question is going to have a vignette attached to it. And you need to read the vignette in order to answer the question. So they can't ask you, or they won't ask you direct things like, which of the following is the most common congenital abnormality in fetuses of moms who have poorly controlled diabetes? Like that will never occur. That's why you have a bunch of text followed by an actual interrogatory. But this is one way, particularly to test sort of epidemiologic information. Mm-hmm. And so which of the following is the most likely abnormality? In order to know that, you need to know what is overall most common and what is also in particular associated with diabetes itself. If you only know the latter, you're going to get it wrong. You're going to know something important about this particular topic, but you're going to get the actual question wrong. So VSD, should be remembered, is not only the most common cardiac anomaly associated with poorly controlled diabetes in pregnancy, it's also the most common overall congenital heart defect.
Right.
So there's that. And then I don't want to take over here, but how else, what other important points would you offer here?
The only other things I really wanted to say was stemming from exactly what you just alluded to, and that would be the distractors in the options here. Anencephaly and spina bifida are both, associated and can be complications of pregestational diabetes that's poorly controlled. But like you said, it's not the most common. So having both of those pieces of information is the key to answering questions like this.
Yeah. And then just quickly, the amelia, which was answer choice A, refers to the absence of limbs. That is not associated with pregestational diabetes, but you have to remember is associated with a famous drug, thalidomide. And it's not to be confused with sacral agenesis, which is sort of like pathognomonic for a type 1 diabetes diagnosis. If you see it on, like a 10 to 12 week ultrasound, sacral agenesis, the likelihood that mom has poorly controlled diabetes is pretty solid. And sacral agenesis is just abnormal development of the lower extremity, lower spine. So, and then spina bifida and anencephaly are common neural tube defects, which, as you mentioned, can be associated with diabetes, but aren't the most common. So some pretty good high yield points there. So
for sure.
Let's move on. A 15-year-old girl comes to the office because of a few incidents of hyperventilation, especially when she's stressed. She denies any chest pain or palpitations and no cardiac history, though her mother does report she has a murmur. Examination shows a late systolic murmur, heard loudest at the apical region, which is preceded by a click. Which of the following is the most likely cause of the patient's murmur? And the answer choices are A, aortic stenosis, B, atrial septal defect, C, hypertrophic cardiomyopathy, D, mitral valve prolapse, and E, tricuspid regurgitation. All right. How would you approach this if you're unfortunately having to take your step 1 exam again?
Oh God, that's a nightmare,
right? But you guys will do fine. Don't worry.
Right. So again, just like with any other question, I always read the first line first and then the question line afterwards. And the one that really stuck out for me, I guess right away from this, I guess this is kind of cheating because I also have a lot of clinical knowledge under my belt, but a 15-year-old girl, and the question is asking about a murmur. So obviously things like aortic stenosis are going to be less likely in my mind just because that doesn't really affect 15-year-old girls too much.
Yep.
The rest is, looking at the answer options and then going through the vignette. There's a pretty classical description of the murmur here. And I think questions are like this typically boil down to whether or not you know the associations between disease presentation and the disease or not, which is the bread and butter of a lot of board questions anyway.
Yeah.
So here the murmur is described as a late systolic murmur, loudest at the apical region, preceded by a click, and there's also questionable family history of a murmur as well. Immediately in my mind, just again from recognition and recall from the material, is mitral valve prolapse.
Yeah.
It just fits the murmur's description to a T, and the murmur description itself helps to eliminate a lot of the other answer choices, such as, the atrial septal defect and the tricuspid regurg, for example.
Yeah. So if you do actually get an interrogatory similar to what murmur is this, essentially?
Right, exactly.
You have two options. To learn that material, you can memorize all the features of the common murmurs that are testable and testworthy, with a mid-systolic click being a really specific sign of a mitral valve prolapse. Or you can study and understand the physiology as to what causes the sounds that correspond with the pathology, which is probably a better option.
Oh, no doubt.
So, people will, what causes the the click, and that is because the mitral valve leaflets kind of like
stick together, right?
Yeah, they stick together, or they stick together, which results in backflow of blood through the mitral valve, leading to the late systolic location of the murmur and the clicking sound of the billowing mitral valve leaflets during cardiac auscultation. So I think it's really important to, in my mind, because this is such an important part of physical exam that illustrates a lot of physiologic principles, to really understand the pathophysiology of murmurs, so that you don't have to, think, oh man, is that harsh systolic murmur over the right second intercostal space? Is that this murmur, or is it actually aortic stenosis, which it is? Mm-hmm. And it radiates to the neck. Why does it do that? I don't know. Do you have any good resources for that? Did you use flashcards to memorize this stuff, or was this a sit down for an afternoon and really go through everything you could to understand cardiac pathophysiology, specifically for murmurs?
So I guess I was a little bit ahead of the game here, because I was a physiology student in undergrad.
Okay.
So a lot of the concepts weren't the first time I was seeing them, but to answer your question, I did both actually. I wrote flashcards for all of this stuff.
Yeah.
But I also, relied heavily on other sources too, especially for conceptual knowledge. Prose text is always my number one. I always find that I've learned best from reading like narrative text, straight out of a Robbins textbook or a physiology text, whatever it is. But the flashcards certainly helped because, there are a lot of patterns in medicine. There's a lot of situations where you need to recognize those patterns quickly, and flashcards really help with that. And a lot of the research into flashcards and namely active recall has shown that there is a lot of benefit in using these kind of tools for conceptual learning and not just enumerated knowledge as well. So, in retrospect, I'm glad I did that, but I did both, to answer your question.
Okay, fair enough. So just to lay this out clearly then, mitral valve prolapse is a late systolic murmur heard loudest at the apical region with a mid-systolic click. That's your mitral valve prolapse. And then answer choice A was aortic stenosis. So you're looking for a harsh systolic murmur heard loudest over the right second intercostal space, which radiates to the neck. B was an atrial septal defect with kind of the classic finding or unique finding for ASD being the fixed splitting of S2. Hypertrophic cardiomyopathy is similar to aortic stenosis, but is a crescendo-decrescendo systolic murmur, best heard at the left upper sternal border. Those are the kind of things you would see in a physical examination description of someone with hypertrophic cardiomyopathy who would present with possibly syncope, ischemic chest pain, and or arrhythmia. And then tricuspid regurgitation, which was choice E, is also a systolic murmur, which is typically described as having a mid-diastolic rumble, and you'll likely see distended jugular veins from increased right atrial pressure and backup of blood in terms of venous return. So any other high yield murmur points before we go on to?
This is a good mirror of the first question too, and sort of how to approach the question, I think.
All right. Moving on to a 43-year-old woman who comes to the office because of palpitations for the past month. She says the palpitations are intermittent and are not caused by anything in particular. Medical history is significant for a cardiac murmur since childhood. And examination shows a soft diastolic murmur heard loudest at the left fifth intercostal space. Which of the following most likely represents the etiology of this patient's murmur? Is it A, aortic annulus dilation, B, atrial septal defect, C, a patent ductus arteriosus, D, a pulmonary valve stenosis, or E, repeated bouts of acute rheumatic fever? And the answer here is E, repeated bouts of acute rheumatic fever. what leads us to that answer and helps us rule out the other choices?
I like this question because, I didn't have too much difficulty with it now, but I can almost guarantee you that back in step 1 prep, I would have had issues with this question.
Absolutely.
So I think what really, really helps us here, and I think if students, find themselves sitting in front of a question like this, is to kind of play the process of elimination game. Because a lot of the times on the test, you might find that, you have the knowledge to understand why an answer choice would be right or wrong. But getting to that answer choice is more difficult than actually piecing together the concepts. So I think this is a good example of a question where you could use that approach. So if we just go through the options, 2 of the options already have systolic murmurs. So they're automatically ruled out. And the ones I'm talking about here are the pulmonary valve stenosis as well as the ASD. They both have systolic murmurs. I think you mentioned PDA as an option as well. And that has a very distinct murmur sound, the machine-like murmur, which I think is accentuated or louder in systole.
Yes.
But regardless, those 3 are automatically ruled out just because of how the murmur is being described here. And if we take a closer look at the options, we have 2 diastolic murmurs, but the one in the question is loudest at the left 5th intercostal space, which is going to point me towards a mitral lesion as opposed to an aortic lesion. And the obvious answer choice at that point is the repeated bouts of acute rheumatic fever.
Yeah. So you can't underestimate how important it is to remember the all physicians take money mnemonic for physical exam.
Huge mnemonic.
Yeah, that's got to be one of the top 10 things.
Yeah, it's up there. It's up there.
That's worth remembering. But I mean, you can sometimes a question is going to be a lot harder than just identifying which valve based on where the vignette identifies the auscultation is happening. But sometimes it really is that easy. So if you feel stuck, I would say come up with a process for approaching murmur type questions. My own mind, I think, probably proceeds kind of along the same pattern that you did here. And that is, okay, where are they listening in the vignette? And it's at the left 5th intercostal space. So that immediately has me thinking mitral, right? Mitral. Mm-hmm. And then, is it heard systolic or diastolic? Well, if it's a mitral or tricuspid stenosis, then it's going to be a diastolic murmur. If it's a mitral or tricuspid regurgitation, it's going to be a systolic murmur, and kind of the obverse is true for the aortic and pulmonary valves. So, I guess that's how I would kind of break it down, is location of auscultation to identify the valve that's abnormal, and then the timing of the murmur, systolic or diastolic, to help determine whether it's a stenotic or a regurgitative process. And I think even if you can only remember that stuff, that'll probably help you get through like 80% of murmur type questions. Mm-hmm. That leaves out, of course, or can leave out, at least from the names of the disease processes, and you just have to memorize them if you didn't feel like doing the hard work of understanding the physiology, like the atrial septal defect, which is the systolic ejection murmur. But the problem with that is it's really a pulmonic valvular lesion, and then PDA is going to be a continuous machine-like murmur, like you said. That's a pretty classic description, but it is kind of a buzzword. So I don't know that you can rely on the machine-like phraseology nowadays. So you'd be looking for emphasis on the continuous nature of the auscultatory finding, and the accentuation in systole would also help. Let's see what else. I think that's... The
patient will probably also be younger than
15.
43.
Oh yeah, that's right. She's 43 in this one. Yeah. And that brings up a good point too. In trying to explain this, here I am like focusing in on just the physical examination findings. But if I were actually stuck as a student and I didn't start thinking about very basic things like the fact that they really aren't trying to trick you.
Right.
Like if a patient's 45 years old or something, they're probably not going to be having a patent ductus arteriosus. That's pretty good info to keep in mind because it helps you immediately rule out one of the answer choices if you're stuck. But acute rheumatic fever, soft mid-diastolic rumbling, heard loudest at the apex of the heart or the left fifth intercostal space. That's mitral stenosis. And I think Elizabeth is actually doing a Group A strep mini episode to go over a little more related to rheumatic fever. So we'll leave it at that. All right, let's do one more.
All right, sounds good.
So we're going to look at a 72-year-old woman who comes to the emergency department because of a brief loss of consciousness, slurred speech, and facial numbness. Family members report that she complained about feeling chest pain and shortness of breath while on her morning walk. Medical history is non-contributory. Physical examination shows decreased pupil reactivity to light and a hemiplegic gait. On auscultation, her S1 is loud and widely split, and there is a diastolic murmur. Her temperature is normal, pulse is 120 beats per minute, respirations are 26 per minute, blood pressure is 160/80. And a transthoracic echocardiograph reveals a large oval-shaped and sessile mass in the left atrium. Which of the following is the most likely complication of this patient's condition? And the answer choices here are A, atrial fibrillation, B, atrioventricular block, C, congestive heart failure, D, mitral valve obstruction, or E, pulmonary edema. When I looked at these questions, this question in particular, and pulled it, I knew this one. I was pretty excited because I don't really deal with this too often. But let me ask you, how would you approach it before we give away the answer?
Again, just sticking to my strategy, reading the question, it's clear to me that it's a like secondary, tertiary type question.
Yeah.
So the first thing is to identify, what this patient has. The big giveaway is, of course, the echo finding, the large oval-shaped and sessile left atrial mass. So that obviously brings like the cardiac tumor or myxoma possibly into my mind.
And that's where I went.
Right. And I think they make that pretty clear with how they describe the echo findings. So once you settle on the myxoma, the other thing is to figure out what the most likely complication is. And then, again, I think it sounds like such a simple thing and like it sounds so obvious, but just reading the question first helped me so much. And it just helps words like most likely complication just stick out to me as I read the vignette from top to bottom.
Yeah.
So the next thing is just to decide which of these answer options, is the most likely complication. Atrial fibrillation is possible, but it's not the most likely. CHF is possible, but it's not the most likely. And again, like how you were saying just now, they're not really trying to trick you. Sometimes keeping it simple is the best way to go. And so mitral valve obstruction, option D, would be the correct answer that sticks out to me. But it's important, once again, just to have the most likely in mind because some of these other answer choices are certainly possible as well.
Yeah, and I think the hinge for this particular question is that, like you said, the echocardiograph finding that large oval-shaped and sessile left atrial mass. So if you have that, what is that going to look like clinically? Well, the left atrium, leads into the left ventricle via the mitral valve. So if I have a mass in my left atrium, could I get AFib? Yes, that's possible, like you said, and you can get all these kind of other things too. But the tumor is most likely to just simply obstruct the mitral valve and lead to her symptoms. So AFib, we'd expect perhaps more in terms of her clinical picture, that they would at least say in the physical examination or auscultation that she's got an irregular rhythm, for instance.
Mm-hmm.
AV block. I don't know that you can really get that without having some ECG report, And
not just that, she's also tachycardic. So
That's
AV block is just less likely as well.
And then CHF, I think, again, you're going to have more in terms of her clinical picture. They're probably going to mention, edema, not just shortness of breath, or chest pain or morning walk, but she's got these other things too that don't quite simply fit with CHF. Loss of consciousness, slurred speech, facial numbness, hemiplegic gait, decreased pupil reactivity to light. So, and then I guess going back to that, what are they trying to describe with the loss of consciousness, slurred speech, essentially the neuro findings? What are they trying to get us to think of?
I think they're trying to nudge the students towards AFib.
So do you think it's simply a distractor there?
That's what I took it as. She's a 72-year-old lady. She possibly has other comorbidities. The lesion that's described, we don't know how long it's been there. It is possible that she has AFib, right? But that's not what's being asked here. So, I guess maybe this is a good opportunity to maybe expand a little bit on how I approach questions. And maybe it's a double-edged sword, and it probably is. But, by reading the question first and the top, I kind of was nudged towards focusing more on the physical exam findings, her vitals, and the echo finding as opposed to her history. The way the question is written, it could be the opposite way for other questions as well. So,
and I guess too, as the question nudges them towards AFib, there's probably a few different approaches to this. I personally tried to answer the question, the interrogatory, prior to looking at the answer choices. But, you're rushed during a standardized exam, and I could very simply or easily see somebody reading this and going, oh, this lady had probably like an embolic stroke. And there's these weird cardiac findings, on auscultations. So yeah, she's probably got AFib. And then, cause that's the first answer choice, I would pencil it in or click on it and then move on. So it's important to really make sure you have all the information here. And in terms of, the myxoma, what is the single best answer here?
Obstruction.
It's obstruction. Even though some of these other things could occur, that's not the most likely complication here. It's obstruction because there's a mass in the heart's left atrium. Anything else on this one?
No, I think that was good. I hope I made sense.
I hope I made sense too, but thank you so much for your time, ladies and gentlemen. That's Amreet, Sidhu, the Brosencephalon.